right, I'd like to thank everybody for coming out today. I'd like to welcome our speaker today, Dr. Vera Luther. Dr. Luther is an associate professor in the Department of Internal Medicine section on infectious disease here at Wake Forest. Amongst her many academic appointments, Dr. Luther serves as the program director for the Infectious Disease Fellowship, as well as the associate program director for the Internal Medicine Residency Program, also infectious disease clerkship director for the med school, and associate medical director for the, and I'm going to have to read this one, Center for Antimicrobial Utilization, Stewardship, and Epidemiology, or as we know, all lovingly refer to it, the CAUSE pager and the CAUSE team. She also serves, apologies. She obtained her bachelor's degree from the University of Missouri, Kansas City, and subsequently her medical degree from the University of Missouri, Kansas City as well through their combined BA-MD program. She completed her residency and chief residency in internal medicine here at Wake Forest, and then went on to fellowship in infectious disease here at Wake Forest as well. And her main areas of interest are antimicrobial decision-making and stewardship, as well as medical education. So on behalf of the Department of Internal Medicine, please join me in welcoming Dr. Luther.
All right. Thank you, Adam, for that great introduction. So our topic for the day is what drives your antibiotic decisions. It's more than what you know. So this topic is just endlessly fascinating to me. It combines the complexity of medical decision-making, education, and behavior change with the critically important topic of judicious antibiotic use. And I say critically important because you could argue that the public health implications of antibiotic overuse are really unparalleled. So our plan for our time together, we'll just briefly talk about the issue of antibiotic use and overuse. Then we'll dive into some patient factors, environmental factors, and clinician factors that play into antibiotic use and overuse. And we'll close with some strategies to improve antibiotic prescribing. So you all are familiar, but it's worth reiterating that antibiotics carry risks. And so we have some known harms. I think the one that's getting a lot of attention, and appropriately so, is the risk of antimicrobial resistance, both in the patient who we're prescribing the antibiotic for and for the patients around us and the public health implications. But there are a whole host of other potential harms, including C. diff, direct drug reactions, and then potential harms. And this is really an emerging area of research. A lot of the potential harms having to do with changes in the microbiome, but things like increased asthma, obesity, and even some mental health effects. And so the scope of antibiotic overuse. So this is a topic that's gained national and international attention really for the past couple of decades. So you'll remember in 2003, the CDC launched its Get Smart campaign. And then more recently, the White House has drawn attention to this problem of antibiotic overuse, the need to combat antibiotic resistance. And the World Health Organization has a strategic plan to combat antimicrobial resistance as well. So how are we doing in the United States? We have made some headway since the Get Smart campaign was first launched, but about a third of our antibiotics are still entirely unnecessary. And of the ones that are necessary, anywhere between a quarter to half are inappropriate. So the spectrum is too broad or the durations are too long. So we certainly have some room for improvement, significant room for improvement. And the issue of antibiotic resistance is so serious that some experts, both here in the United States and internationally, speculate that if we don't reverse current trends, the #1 leading cause of death in the year 2050 will be antibiotic-resistant infections. Okay, so what all goes into antibiotic decision-making? I won't belabor all these points, but the key point I want to make is that it's actually a very complex process, and it relies on accurate data gathering, synthesis of information, application of knowledge, developing plans, generating those plans, and then engaging in shared decision-making with patients and others. And meanwhile, we have to avoid computational errors and biases along the way. And so when antibiotic prescribing is done right, we end up with the right drug for the right patient, the right indication, the right duration, et cetera. But it can go wrong in two different ways. So we can either prescribe unnecessarily, so the patient has a non-infectious diagnosis, viral illness, or we're treating colonization, or inappropriately. So again, the spectrum is too broad or potentially too narrow. There's a bug-drug mismatch, the duration's too long, wrong dose, or delayed administration in critically ill patients. So there are several ways that, that things can go wrong. And interestingly, there's quite a bit of provider variation in antibiotic prescribing. So a lot of the literature, a lot of the data looking at this has been in the outpatient setting, looking at acute respiratory infections, because that was one of the key target areas of the Get Smart campaign. And so looking at the ends of the prescribing spectrum, on the low end of the prescribing spectrum, the 10% of providers who prescribe the least prescribe antibiotics for patients who have acute respiratory infections 40% of the time or less, whereas on the high end, providers will prescribe 95% of the time or more. So there's quite a bit of variation. As we go through our time together, we'll talk about some goals for antibiotic prescribing in this setting, and just a number to kind of hang your hat on. 20% has been cited as a good target for antibiotic prescribing in the outpatient setting for acute respiratory infection. So even those lower end prescribers could still do better. Okay, so I want to take a moment and have you pause and turn to your neighbor, actually, and take a moment to reflect on your own experiences and ideas. Can you recall a time when you prescribed an antibiotic that perhaps wasn't really necessary? And if you don't prescribe antibiotics as part of your routine practice, just brainstorm about what do you think some key drivers are. So go ahead and chat with your neighbor for a moment. Okay, go ahead and wrap up. Thank you for sharing with each other. You guys did great. There were a lot of good conversations there. So let's dive right into some factors and see if you discussed any of these. So if you discussed patient demand or patient expectations, you would be in good company. So this is actually the #1 reason that's cited by clinicians for reasons why they overprescribe. And a patient's desire for antibiotics is an independent predictor of antibiotic receipt. And interestingly, patient expectations have changed over time. So literature from the 90s indicated that 60 to 75% of adults with URIs wanted antibiotics for that, whereas more recently, 10 to 40% of adults with URIs want antibiotics. So the public has been changing, and what patients want has been changing. Okay, and then interestingly, patients oftentimes don't overtly ask for antibiotics, and so we as clinicians kind of make inferences about what they really want based on communication behaviors. So I just want you to think to yourself as we go through a couple of examples. Imagine that you had a 40-year-old female coming to see you in clinic with some upper respiratory symptoms. And what if she said to you, symptoms only, problem presentation? What if she said, I have runny nose and sore throat? So think to yourself, would you think that she automatically wants antibiotics? How about if she used a candidate diagnosis problem presentation? How about if she said, I've had a terrible sore throat, so I thought maybe it was strep. So what would that say to you? Or how about after you give her her diagnosis, she says, it's just that this has been going on for so long. So that's called diagnosis resistance. Or how about after you suggest that she uses some over-the-counter treatment medicine, she says, over-the-counter cough medicine, she says, well, the Robitussin just isn't working. So in your mind, which one of those would you think means that she wants antibiotics? So in the study, physicians identified a candidate diagnosis problem presentation and diagnosis resistance as meaning patients want antibiotics. But interestingly, none of these communication behaviors were correlated with the patient actually wanting antibiotics. So it's hard for us to actually know what they want. So we as physicians or clinicians identify what patients want in terms of antibiotics about a quarter of the time. We're accurate at predicting that about a quarter of the time. And most patients do deny a priori expectations of antibiotics. And so what do they want besides antibiotics? Well, they want a whole host of other things, including just a diagnosis, relief of symptoms, relief from pain, and reassurance. And it's really important. There are a lot of studies looking at patient satisfaction and antibiotic receipt. Patient satisfaction does not increase with antibiotic prescription, but it does increase when patients leave feeling like they have a better understanding of their illness. And clinicians who don't appreciate that there is a tension when patients want antibiotics and you as a prescriber don't think they're indicated, if you don't think that's a problem and that creates some tension and conflict, then you are more likely to overprescribe. And then there's also the issue of our own satisfaction in addition to patient satisfaction. So I think this is a telling quote that's from some qualitative research looking at some of these factors. But physician quote here, a person who has taken time off of work, come into urgent care, and then for me to turn them around and say, keep doing what you're already doing, I think in some ways doesn't feel very satisfying as a physician. So we have that to think about as well. And then I'll just briefly touch on the influence of others. So if our patients don't necessarily want antibiotics, what about family members and caregivers? So this is an issue that comes up certainly in the pediatric literature. There's a lot written on this, but also now in the geriatric literature. And so particularly as we look at stewardship in long-term care facilities. And a couple of quotes from some qualitative research that was published in 2014. I think we can oftentimes relate to this. So a long-term care facility nurse says, sometimes the urine is checked because it is just very nasty, very concentrated, or it smells very bad. Or another quote, I sometimes call directly to say there are unmistakable signs of an infection, come and prescribe antibiotics. So we do have those caregiver expectations sometimes that we need to deal with and address, certainly. Okay, so what are some patient demographics that are associated with antibiotic overprescription? So older adults are more likely to be overprescribed antibiotics, female gender, and this graph here looks a little bit into why would females get antibiotics more often than males, and it's really because females go to the doctor more often than males, and so the circles here are visits and the triangles are antibiotic prescriptions for a whole host of indications, and when you look at how many visits there are versus receipt of antibiotics, really females don't get antibiotics more often per visit, they just have more visits. And other factors, other patient factors, are the presence of comorbidities, being white or Caucasian, and having health insurance. Those are risks for antibiotic overprescription. And then some patient signs and symptoms. So the presence of a cough, fever, discolored sputum, shortness of breath, and chest sounds on auscultation are associated with overprescription. And interestingly, there's some research that's being done on the wide variation in clinician assessment of breath sounds, and that standardization and improving clinical skills is one way to address some of the overprescription that occurs. And then I just wanted to briefly mention the importance of antibiotic allergy. So as you know, patients oftentimes report an antibiotic allergy when, in fact, they don't have one, or perhaps they had one a long time ago and it's really not an issue anymore. But reporting a penicillin allergy is a significant predictor of inappropriate treatment, and patients who report a penicillin allergy are 7 times more likely to receive inappropriately broad therapy. So really clarifying allergies is an important thing that we can do. Okay, environmental factors. So we'll just touch on a couple of these, but there are a lot of environmental factors that can come into play with regard to antibiotic prescribing, including time pressure, the electronic health record as part of our environment, various organizational policies, guidelines, the presence of feedback from the organization, and the influence of pharmaceutical representatives, which can be a factor in up to 20% of decisions here in the United States. So the volume-quality relationship has been looked at. So for certain specialties, for example, in surgery and for some high acuity conditions, there's a positive volume-quality relationship where the more surgeries you do, the better your outcomes are. That is not true for antibiotic prescribing. So higher volume providers, higher volume clinics are associated with overprescription, so not more appropriate prescribing. And then the subjective feeling of being rushed is associated with antibiotic overprescribing. And about 1/3 of us feel that way almost always or most of the time. Okay, so just a quick question. Turn to your neighbor. What time of day do you suspect antibiotic prescribing is the least appropriate? What's your best guess? Okay. All right, did you think of an answer in your mind anyway when you think the antibiotic prescribing might be least appropriate? So let's check your answers. So if you said later in the afternoon or later in the clinic session, you would be right. So looking at outpatient prescribing, this graph here is looking at antibiotics overall, sometimes indicated and never indicated. And when we compare 8 a.m. to 1 p.m., 9 a.m. to 2 p.m., and so forth, the afternoon is associated with less appropriate prescribing. And that's thought to be due to the concept of decision fatigue that occurs over time. So we as clinicians are making a lot of complex decisions throughout the course of the day, and we get tired, and so overprescribing tends to occur. But if you said the morning, you would also be right. So looking at inpatient data divided into chunks of the 8 a.m. to 1 p.m. time frame, 1 p.m. to 7 p.m. time frame, and then the evening overnight, 7 p.m. to 8 a.m., there's a morning dip in appropriateness of inpatient prescribing. And so there's still more work on trying to figure out why this is, but in doing some qualitative research for these physicians who responded, they really attributed it to having a lot of interruptions during the morning. So a lot of pages coming in, nursing questions, needing to talk to patients, write their notes, and just kind of the hubbub of the morning. Whereas in the afternoon, they felt like they got a little more time to sit down and really be thoughtful about their prescribing. Okay, and then just briefly touching on the electronic health record. So design matters. So the design of the electronic health record can hurt us. So some examples are alphabetical listings, so lists of allergies, lists of antibiotics in an order set. So if you do that alphabetically, like amikacin is first, which is rarely our first line. IV route as the default for antibiotics, that can be problematic. And then in terms of diagnostic stewardship, we can actually see over testing occur because of diagnostic test lists. So too many tests are listed, or the expensive ones are listed before the more routine, inexpensive ones. And just to look at our own EPIC, you can see our allergy reactions. Anaphylaxis is listed first. And since we moved to EPIC, the amount of supposed anaphylaxis we're seeing has just skyrocketed, as has the number 2 option there, angioedema. So that's actually a very rare thing, but we're seeing a lot of it because that's the number 2 listing. Okay, so moving on now to clinicians. So clinician demographics associated with higher antibiotic prescribing are age 40 and over, male gender, people who are in solo or 2 physician practices, and people who practice in the South. So to orient you to this map, the lightest lavender states are the states with the lowest prescribing rates. The darkest blue states are the states with the highest antibiotic prescribing rates. So you can see the South is the densest area. We in North Carolina are actually not in the top tier. We're 3rd from the top, but we certainly have room for improvement. So which specialty prescribes the most? That's actually a really complicated question, and there's some conflicting data. But one thing we do know is that pediatrics has made amazing headway over the past couple of decades in terms of their antibiotic appropriateness. So they outperform internal medicine and family medicine in terms of appropriateness. And if you really want to increase appropriateness, get an ID consult. So that increases appropriateness by about 30%. Okay, let's talk a little bit about career stage. So the intern year is associated with antibiotic overprescribing. So this is true both in the United States and Europe, and both in the outpatient and the inpatient settings. But interestingly, once we get through the intern year and move on to second year, residents outperform attendings in terms of appropriateness of prescribing. And so remember, as a target here for outpatient prescriptions for acute respiratory infections, 20% is a pretty good number, a benchmark. So resident physicians are still overprescribing, but much less than their attendings. And then as we go farther out into practice, later career stage is associated with overprescribing, and particularly with prescribing long durations for respiratory infections as well as urinary infections. And when we say late career stage, that's people who've been in practice 25 years and longer. How about telemedicine? So this is a unique and emerging practice setting, and you can imagine, because we can't actually lay hands upon patients, antibiotic prescribing might be an issue here. But at least from a very recent study out of Cornell, it seems like that is not the case. So they looked at about 500 visits and found no difference in prescribing for acute respiratory infections. Okay, so knowledge. I think knowledge is kind of the elephant in the room in terms of clinician factors. So it makes sense to us to think that if we could only make sure everyone knows the guidelines and everyone knows the right thing to do, then the problem of antibiotic overuse will go away. And so what do we know about knowledge? Well, the data from systematic reviews and meta-analyses seem to show that clinicians have a pretty good awareness of the concept of antibiotic resistance and the link between antibiotics and resistance. And they're generally familiar with guideline recommendations for common infections. And we know that educational efforts targeting clinicians do improve knowledge, they improve antibiotic use, and education is one of the core elements of antibiotic stewardship. So it is very important. And there are gaps in clinician knowledge. So this is a study that was done out of a Midwestern hospital, qualitative research, but really posing scenarios to physicians and then asking them to discuss that scenario in the context of the current guidelines and their understanding of those guidelines. And so I think one telling quote is, with regard to an asymptomatic bacteriuria scenario, the physician says, "I know after you reach a certain age, we generally treat you even though you don't necessarily have symptoms just because of all the risks associated with having bacteria in your urine." And that's false, of course. So older age is not a reason to treat asymptomatic bacteria. So there are certainly knowledge gaps that we ought to address. But knowledge of the guidelines isn't enough. So I wanted to share with you data from one study we did here at Wake Forest. So if you participated in this study, thank you. But we gave scenarios to over 200 physicians here and looked at treatment decisions for asymptomatic bacteria, non-purulent cellulitis, bronchitis, pharyngitis, and rhinosinusitis, and then looked at guideline concordance. And when we asked which of the following treatment decisions should be made for the patient according to treatment guidelines, the Wake Forest physicians did really well. Actually, 83% were using guideline concordant decisions, and that's along with some of the highest rates cited in the literature. So great job. But interestingly, when we tweaked the question and asked which of the following treatment decisions would you make for the patient, that number went down significantly. So people were not making guideline concordant decisions when they imagined what they would do in real life. So that's very odd to me, that they clearly knew what to do, but also knew they wouldn't do that in real life in certain scenarios. So why is that? And this type of phenomenon where physicians or clinicians know what to do but then do something different in real life, that's been described in other studies as well. So other than knowledge, what clinician decision factor do you think might be influential in antibiotic prescribing? So talk for a minute to your neighbor. All right, go ahead and wrap up. Okay. All right, so lots of good conversation there. So if you said any of these factors, so fear or concern, complacency or inertia, uncertainty, external responsibility like not my problem, or beliefs like indifference, then you would be in good company with what is published in the literature. So we wanted to investigate this a little bit more here at Wake Forest, so I wanted to share some results of a study we did here to look at what are some of these factors that influence antibiotic prescribing in addition to knowledge. So again, if you happen to participate in this study, I thank you, but we enrolled physicians and asked them to complete a baseline knowledge exam as well as a relatively lengthy medical decision-making inventory looking at reactions to uncertainty, concerns about bad outcome, risk-taking, resistance to change, a general decision-making questionnaire, and fear of negative evaluation, which has to do with kind of concerns of how your peers would view your decisions. And then this was back in the days of CareCast, so before Epic. But we used a pop-up survey in SIPO, so every time a physician entered an order for an antibiotic for an older adult, because this is an area of overuse, they got a brief survey asking about their decision-making and rationale, and then a follow-up survey 96 hours later to ask about de-escalation decisions. And so we enrolled 58 physicians. We looked at 258 antibiotic decisions, and then we calculated appropriate decision-making scores based on the infection they were treating and comparing it to available guidelines. And there was a broad range in appropriate decision-making scores, between 12% appropriate or guideline concordant up to 80%, which is, again, 80% is the higher range of what else is out there in the literature. And so in terms of what folks were thinking with their initial antibiotic decisions, concern or fear certainly came into play and was something that was cited over half of the time. About a third of the time, folks were uncertain that the patient needed an antibiotic, and then others were often involved in the decision-making. Interestingly, ID was only involved about 7% of the time. And so reasons for de-escalating, patients improving and having culture results, that was really helpful in terms of encouraging de-escalation, but interestingly, those reasons are also cited for reasons for not de-escalating, as well as the patient not improving, lack of confidence in microdata, and a whole host of other things. And we also found there was not a correlation between their appropriate decision-making score and their knowledge exam score. So that was kind of an interesting finding. We did find an association with people who had higher appropriate decision-making scores scored higher on the vigilance aspect of the Melbourne decision-making questionnaire. So their approach to decisions was considered a vigilant approach as opposed to a more laissez-faire or procrastinating avoidance approach. So people who are comfortable making decisions and are really kind of wanting to think through things seem to make better antibiotic decisions. And then kind of a surprising finding on the resistance to change inventory, people who scored highly for having cognitive rigidity had much higher appropriate decision-making scores. And so I'm not sure why that might be, other than maybe they wanted to follow guidelines or feel comfortable following guidelines more. And then in terms of de-escalation decisions, physicians who scored high on the reaction to uncertainty, so they found uncertainty very uncomfortable, they were less likely to de-escalate. So that kind of makes sense. Okay, so let's talk a little bit more about the issue of fear or concern. So again, that was something that our physicians cited over half of the time. And so there's lots to be concerned about in medicine, and really it's good for us to be concerned. So we can be concerned about missing something or an adverse outcome in the patient or even losing the patient. And when that fear becomes disproportionate, that's referred to as the chagrin factor, or decision psychologists also refer to it as counterfactual thinking. So you have a patient who weighs heavily in your mind because they didn't do well, and you think to yourself, oh, I shoulda, woulda, coulda. If only I had had them on vancomycin the whole time, they would have done better. And so that's counterfactual thinking. It's thinking that it's not necessarily true, but trying to prevent that adverse outcome in the future. And so data from qualitative research looking at fear and concern really indicates that we as physicians view antibiotics as the safe option. So when we're concerned about our patients, we are much more likely to overprescribe because we view that as a safe thing to do and don't think about those consequences that could occur. And I think the last quote here is kind of telling. So I think you're going to look bad if you miss something and did not treat it appropriately versus giving people C. diff and diarrhea, which is a little more anonymous. So this person even realized that C. diff could happen and still thought that giving antibiotics would still be the better choice. Okay, a little bit about complacency. So complacency has kind of negative connotations, but it doesn't need to. Complacency is really something that's necessary for efficiency. So it's when we have habits and kind of get in the routine of doing things. So some degree of complacency is okay, but when we're talking about behavior change and improving antibiotic use, complacency is an obstacle to overcome. And so, interestingly, prior prescribing tendencies are a significant predictor of current practice. And illustrative quote, habits are hard to change, I'll say that. So if someone's used to writing Zithromax, they're not going to stop because it's easy. Patients want it. So this has also been described as clinical inertia. And then complacency also has come into play with regard to patient requests or patient satisfaction and just kind of wanting to give in to appease the patient. But remember, there's no correlation between satisfaction and antibiotic prescription. Okay, so how about uncertainty? These concepts are certainly interrelated, but the concept of uncertainty is significant. So there's a lot in medicine for us to be uncertain about. We can be uncertain about the clinical diagnosis, potentially a microbiologic diagnosis, if we're not able to identify a virus and tell a patient 100% for sure that's what you've got. We can be uncertain about what are the newest guideline recommendations and concern about an individual's ability to follow up and what could happen to them. And I wanted to take a moment to recognize two pillars of our institution and their work in creating awareness and describing the issues and challenges surrounding uncertainty in medicine. So Pat Ober wrote about the cascade effect in clinical medicine, and Jim Peacock is credited with coining the term spiraling empiricism, when we treat uncertainty with antibiotics and things spiral out of control. And uncertainty certainly comes into play with regard to treatment of upper respiratory infections and bronchitis. And so there's one interesting study that looked at uncertainty as documented in the medical record. So when physicians wrote patients presenting with question acute bronchitis, or if they said unclear etiology or one diagnosis versus another, that kind of documented uncertainty. And so as the degree of uncertainty went up, the antibiotic prescribing went up also. External responsibility. So this is an issue. So a couple of studies have looked at physicians oftentimes agree that antibiotics are overused, but some studies certainly say that physicians are saying, but it's not me, it's that other guy. And so one study out of Boston specifically quoted physicians as saying, well, my colleagues really don't understand acute bronchitis, and my colleagues are stuck in the habit of prescribing antibiotics, but not so much wanting to take ownership. And then other beliefs, such as indifference to the problem, so not even recognizing that there is a problem, or knowing there is, but just accepting it. So that is a dangerous thing. Indifference can be dangerous. And then a whole potpourri of other beliefs, such as whether or not prescribing will increase your workload, an understanding of how others practice, so kind of social norms, and then an understanding of what it means to provide patient-centered care that can influence your prescribing. So one study was looking at, well, maybe some of the reasons for indifference is actually lack of empathy and burnout, but that doesn't seem to be the case. Interestingly, they did not find an association between empathy and burnout or antibiotic prescribing. And I just wanted to briefly mention a study we did here, which was a case-based reflective thought task conference on antibiotic decision-making. Our goal was to address not just knowledge, but also some of these other decision factors that come into play. So we did this first with internal medicine residents and then with family medicine residents, taking folks through an assessment, causal analysis, identifying biases and counterfactuals, talking about implications and solutions. And we found it really helped. So at baseline, exam scores for antibiotic decision-making were very similar between medicine, internal medicine and family medicine. After the intervention, internal medicine scores went up, and then we did the intervention with family medicine, and their scores went up. And the difference was sustained over a year. Okay, so what can you do in your individual practice to improve antibiotic prescribing? So the first thing is just knowing where antibiotics are overused. So if you encounter these scenarios, you know, I need to be thinking about what I'm doing here. So in the outpatient setting, it's really respiratory infections, sinusitis, bronchitis, pharyngitis, nonspecific URI, and uncomplicated cystitis. And then on the inpatient setting, community-acquired pneumonia, UTIs, skin and soft tissue infections, the empiric coverage of MRSA, so we do that too much. We give too much vancomycin. C. diff infection, so if a patient has C. diff, get them off of the other antibiotics so that they can recover from their C. diff. And then the treatment of culture-proven invasive infections. That's an opportunity to de-escalate and streamline. And the CAUSE website is a great resource for treatment guidelines, so I would refer you to that website. And then a couple of other key points. So be sure to make a diagnosis to the best of your ability. Don't treat viral infections or bacterial colonization. Make an accurate allergy assessment. Make de-escalation part of your routine, and use appropriate durations of treatment. And then I just wanted to briefly touch on a couple of communication strategies that have been shown to work. So one is using online commentary during your physical exam. So if you have taken a history from a patient and you're thinking, you know, I'm thinking this is a viral infection and that they most likely don't need antibiotics, using online commentary to talk about your findings as you examine the patient to help build the case against antibiotics is associated with a significant reduction in inappropriate prescriptions. So no problem online commentary would be examining the patient and saying, oh, your lungs sound clear, or your throat is just a little red, as opposed to saying, identifying problems like, oh, your tonsils are very red, or your glands are very swollen. Even though that might not necessarily mean a bacterial infection, patients associate that with the need for antibiotics. Excuse me. And then a couple of other tips are to combine negative treatment recommendations with positive treatment recommendations. So when you discuss with the patient that you think they have a viral illness and that antibiotics won't help, tell them something they can do to help. Even if it's an over-the-counter medication, even if it's taking ibuprofen or taking plenty of fluids, giving those recommendations for symptomatic relief in combination with the negative treatment recommendations has been shown to reduce unnecessary prescribing by 85%. And it does increase patient satisfaction. And then if you just do plain old education, that actually helps also. So using the ask, tell, ask strategy, where you ask or inquire about their understanding of bronchitis, you tell them about the expected duration of their symptoms, how often those are viral in etiology, and then you ask for clarification. That helps reduce prescribing as well. And then in terms of antibiotic prescription disposition, you have a couple of options. So if the patient's really expecting antibiotics, you could give in and prescribe them, and the patient will take the antibiotics 91% of the time in that instance. You can also give them a contingency plan. So you don't think antibiotics are warranted, they really do. You can say, well, you know, I think this is really going to improve, and so if you're not better in 3 or 4 days, then come back and we'll reassess the need for antibiotics then. And in those circumstances, only about a quarter of the patients actually ended up getting antibiotics. So that results in decreased prescribing. You can also do a delayed antibiotic prescription. So they can leave your office with an antibiotic prescription, but you instruct them, don't fill this unless you're still having symptoms 3 days from now. And so that does result in decreased prescriptions and decreased antibiotic use, but not to the extent that a contingency plan does. But it could be a potential way to compromise with your patient if you have someone who really is insistent. And then you could also just stand your ground and hold firm. Interestingly, though, about 12% of the time, patients are still going to get an antibiotic then, whether it's going to another provider or, you know, finding an old prescription bottle. Interestingly, looking at those 4 potential outcomes, there's no difference in patient satisfaction scores. If you opt for delayed prescribing, the CDC has a nice example of the information to give to your patient. So not filling the prescription, and then also some symptomatic things they can do. And just a prescribing tip, if you opt for this, write an expiration date on the prescription so they don't fill that prescription like months later. And then giving patients literature, so handouts or brochures. So this results in a modest decrease in antibiotic use, only like 5%, but it does significantly increase clinicians' confidence. So if you feel like this is something you want to incorporate into your practice, there are some good templates and brochures on the CDC website. Making a public commitment is something that decreases antibiotic prescribing by about 20%. Again, there's a template on the website. And then the last strategy I'll talk about is a concept called nudges. So nudges are something that are lifted from behavioral economics and social psychology literature. And it's really acknowledging that physicians are influenced by their environment, by their own psychology, and by sociology about what others think of them. And so in this study that looked at over 150,000 visits for acute respiratory infections, first of all, just to orient you, the gray circles are the controls, and then the triangles are the interventions. So as you can see, antibiotic prescribing just from being in the study went down. So participating in a study will help your prescribing. But all three of the nudge interventions seem to work. So I'll briefly describe them. The first was accountable justification. So that's something we do here, which is entering an indication for the antibiotic you're prescribing. And so that decreases prescribing. It's an opportunity for you to take a time out, and then also it's in the medical record, so it's publicly there for you to kind of justify your behavior. Peer comparison, so prescribers who were in the top 10% were told that they were top performers for appropriateness. Everyone else was told they're not a top performer. That was very powerful. And then suggested alternatives. So in the electronic medical record, if a diagnosis was entered that is not typically associated with being something that ought to be treated with antibiotics, then suggested alternatives would appear. So all three of those were really helpful. And then we looked at accountable justification here at Wake Forest, just to kind of see what people think of that. It looks like folks are doing a pretty good job in terms of being accurate and taking it seriously and taking it as an opportunity to be thoughtful and have a timeout. And most people thought it was only moderately or modestly burdensome, but there are a few who thought it was very intrusive and taxing, and that's probably to be expected. It does add a little bit of time, but that is something we do here, and now you know why. All right, so take-home points. Clinicians generally know, but don't always follow established guidelines for appropriate antibiotic use. We don't accurately predict what patients want, and even if patients expect antibiotics, they are willing to forego them if we explain why they're not needed, give them some positive treatment recommendations, and suggest contingency plans. And knowing is only half the battle, so knowing the guidelines, knowing the right thing to do is important, but keep in mind these other things. So in addition to patient expectations, time pressure, fear or concern, and clinical inertia or complacency. And I wanted to just end by acknowledging the cause team. So a lot of you may not know the cause team was one of the very first antibiotic stewardship programs in the entire country. So established in the year 2000, Chris Old, Jim Johnson, Jim Beardsley, and John Williamson. And because of continued work of the cause team through the years, we recently here at Wake Forest have received IDSA's highest accolade for antimicrobial stewardship, and we are a Antimicrobial Stewardship Center of Excellence. All right, thank you.
So we'll open up the floor for questions.
That was a great presentation, thank you. I'm in primary care. What's the best antibiotic to prescribe to someone you don't think needs an antibiotic? Safest.
Well, that's a good question. So if you are ending up kind of giving in, I would say, first of all, guideline concordant, but narrower is better. So the narrowest spectrum you can go is the best. So amoxicillin for respiratory infections generally is going to be a narrower choice. But try to not let them leave the office with an unnecessary prescription.
Again, we're always learning all the time, and it's terrific. How important is it that we have conferences like this where we get together and share, and does that really affect the quality of what happens in an environment?
Yeah, so I think that in order for us to continuously improve, it is really important for us to take time out, come together, and share ideas with one another, and taking some time to reflect on actual application and barriers to application, I think is really important.
How much do you think, or how much don't you think, the way we document the antibiotic allergies in the electronic health record compounds the situation. Ours often, I mean, these are old people, so they have long lists, and the intolerances and the severe allergic reactions are kind of thrown into this stew, and different people enter information, and it's rarely pruned.
Yes, I think that is a huge area, and you've really hit the nail on the head in terms of one pretty easy way that we can improve patient care, particularly with regard to antibiotic use. So verifying the allergies, talking to patients, and then there's going to be more coming out on being able to do allergy testing for patients where it's really not clear from their history, so that we can prescribe the narrower spectrum antibiotics and prescribe the most appropriately for people, because so often those allergies are just entirely incorrect. But if you can clarify based on history alone that it doesn't sound like the patient had a genuine allergy, absolutely make that change in the medical record, because we do have inaccurate documentation and intolerances listed as anaphylaxis, and that's a huge barrier to patients being able to get the antibiotics they need. And I'll say it's not just an issue with antibiotic overuse, but also in critically ill patients. So when that patient then comes in with sepsis, some of our best workhorse antibiotics are the beta-lactams. And if they can't get those because of this concern, their outcomes are not as good.
All the way back here. Thank you for a great talk. To sort of follow up on that, and picking on the EMR, of course, which we all love to do, myself included. So you talked about Epic, which loves to do things alphabetically, which is like the dumbest thing ever. It doesn't make a bit of sense. I mean, I understand some human, I mean, it didn't come out of the primordial soup, but some human had to think that was a good idea. But it's such a obviously bad idea. Why don't we put things in order of, like, vague medical appropriateness or something like that, or commonality, or anything, just randomly would be better than alphabetical, more than likely. Is there any, I mean, I know you didn't make up Epic. Is there any possibility of changing that to, like, anything more appropriate in anything?
Yes, so there are ways to change electronic health records. And I'm looking at George, who just came back from Wisconsin and had some profound Epic training. So there are some ways to modify electronic health records, but of course that takes time and resources, and I personally don't know all the logistics of how to make that happen, but I'm sure we can enter a ticket.
Any other questions for Dr. Luther? All right, well, thanks everybody for coming out. Don't forget to fill out your evaluation form.